Rheumatoid arthritis. Rheumatoid arthritis is not a new disease, but as seen in old paintings, it was already present in the 16th century. It's a fairly common disease in comparison to other rheumatological diseases, with a prevalence of 0.3 in the general population. The disease involves the joints that undergo a specific inflammatory pattern called synovitis. It's a chronic polyarthritis, more than 5 joints, symmetric, additive, progressive, and destructive, mediated by an immunological mechanism. It specifically involves synovial joints, those characterized by good mobility. Its incidence is 16.5 to 38 per 100,000 per year in Western world, prevalence of 0.3%, maximum incidence of 40-50 years. At 40-50 years, the prevalence increases with age, more frequent with increasing latitude, and males are less affected than females, with a ratio of 1 to 2 or 3. We have an increased risk of cardiovascular disease, lymphoproliferative neoplasms, like Sjogren's syndrome, and osteoporosis. Genetic risk factors. There is a strong genetic component, even if it is not as clear as we would like it to be. There is around a 12% concordance between monozygotic twins, and 12% means that there is a genetic predisposition, but there is also a role of stochastic events acting on a predisposing background. There is a small increase in the relative risk of developing rheumatoid arthritis in first-grade relatives of affected patients. Relative risk of 2. Quite a lot of focus has been on the MSC molecule, in particular of the MSC class II molecules. These are old studies that mapped a specific series of residues called shared epitope that are 5 amino acids lying in the peptide binding groove of HLA-DR beta 1. Termed shared epitope suggests the existence of an autoantigenic peptide that has not unequivocally been identified or characterized after 2 decades of research. Even in large population studies in which they mapped the HLA-DR beta 1 involved, they have found that also a single amino acid substitution within this sequence is sufficient to confer an increased susceptibility to develop rheumatoid arthritis. For example, having a serine instead of a valine, as seen in the image, completely changes your relative risk. There is an autosomal trait in rheumatoid arthritis, an autosomal inherited trait in rheumatoid arthritis, and you do find that there is a locus that is involved which codifies 4 important molecules in antigen presentation. The possible No, there is an autoimmune trait in rheumatoid arthritis. The possible reason is that we do need the specific peptides binding in the groove for the activation of antigen-reactive T cells, which drive the pathology. There is surely an autoimmune-mediated component to the disease, but it is not easily replicated with synthetic single autoantigen sequences. Non-MHC associated genes have been intensively studied, and all of them are involved in the crosstalk between antigen-presenting cells and T cells. This supports the idea that the genetic component of rheumatoid arthritis is associated with a deregulated activation of autoreactive T cells, PTPN22 intracellular signaling in T and B cells, TRAF1, STAT4, and other signaling molecules. We have also environmental risk factors. It is important also to consider environmental risk factors, and they have been studied extensively in the last years, like response to environmental triggers through changes in the epigenome, post-translational histone modifications and DNA methylation, etc., influencing gene expression. There is an epigenetic alteration, particularly in chromatin hypo and hypermethylation. The most convincing studies have been performed by comparing cells retrieved and purified by joints of rheumatoid arthritis patients with those from non-autoimmune immune arthritis like osteoarthritis patients. This control selection makes sense because the inflammatory response in osteoarthritis occurs because of the injury and not as in rheumatoid arthritis where the injury is caused by the inflammatory response. If we would compare rheumatoid arthritis fibroblasts with normal joint fibroblasts, all the gene expression profiles would be different because of the inflammation ongoing in rheumatoid arthritis, but it will not give any specific information on this self-sustaining event occurring in rheumatoid joints. Global chromatin hypomethylation in cells derived from rheumatoid arthritis patients was found in comparison with those from controls, and different methylation was found especially in cell movement, adhesion and trafficking loci. Events possibly involved in these epigenetic modifications favoring the disease could be cigarette smoking, which has a possible role in the induction phase in susceptible subjects, and there is a significant association with the development of anti-citrullinated C-peptide antibodies. This risk factor is particularly important for patients that have the shared DR4 sequence discussed before. Consensus is that smoking involves the upper airways but also can induce some important post-translational modifications of proteins such as citrullinations that is a major source of autoantigens. This could be a link between rheumatoid arthritis and smoking, and thus why we suggest rheumatoid arthritis patients to stop smoking. We have microbiome, microorganisms that populate skin and mucosal lining organs. Microbial degradation products might contribute to the initiation of rheumatoid arthritis by activating the innate immune system, and since it is involved in the education of the innate immune system, it can be that specific features might facilitate the immune response driving the disease. TLRs are receptors that activate the innate immune system, response to exogenous pathogen-associated molecular patterns or to endogenous damage-associated molecular patterns. TLR2 and TLR4 are expressed in the rheumatoid synovium. Other factors involved can be silica exposure to traffic pollution and high birth weight. Synovial membrane is a loose structure inside the arthrosis joints where it covers all the structures of it except cartilage. The name synovium comes from the egg's ovum in Latin because there is an inner layer within the egg which is extremely thin. And in normal conditions, the synovium is indeed composed of only one or two layers of cells. These are supported by a very thin layer of connective tissue involved in the vascularization of the structure. Immune cells are macrophages and synoviocytes for the production of synovial fluid for lubrication of the joint. Synovial fluid also supports the avascular cartilage by allowing nutrients to diffuse to it. The inner lining of the joint cavity, except cartilage, gets in touch with capsule and thesis. So it's the inner lining of the joint cavity, except cartilage. It gets in touch with a capsule and thesis, tenosynovial or entesosynovial complex, bone. Structural features are in the intima, A and B synoviocytes, and in the subintima, extracellular matrix, lymph nodes, and blood vessels. Cell functions are phagocytosis, type A synoviocytes, macrophage-like, and secretion, type B synoviocytes, fibroblast-like, like GEGs. Tissue function are maintenance of joint structure, joint lubrication, temperature maintenance, reduction of friction and wear of the articular ends, and nutrition of chondrocytes. Pathogenesis of rheumatoid arthritis. So in early rheumatoid arthritis, the synovial membrane becomes thickened because of hyperplasia and hypertrophy of the synovial lining cells. An extensive network of new blood vessels is formed in the synovium. T cells, predominantly CD4 positive, and B cells, some of which become plasma cells, infiltrate the synovial membrane. These cells are also found in the synovial fluid, along with large numbers of neutrophils. In the early stages of rheumatoid arthritis, the synovial membrane begins to invade the cartilage. In established rheumatoid arthritis, the synovial membrane becomes transformed into inflammatory tissue, the pannus. This tissue invades and destroys adjacent cartilage and bone. The pannus consists of both type A and type B synoviocytes and plasma cells. Originally, we have hyperplasia synovial membrane. That advances with the progression of the disease until there is a specific structure called pannus which erodes the bone surface in touch with the synovia. This is an extremely important event in the natural history of the disease because when you start to erode the bone, the disease cannot be reversed anymore. Until that point, you are at least able to freeze the disease progression. The pannus is made by hyperplastic folds of the membrane with an important leukocyte infiltrate, especially of macrophages, CD4 positive T cells, and neutrophils, which are also found in the synovial fluid in the early phases of the disease. We do not know much about the very early phases of the disease, mostly because patients don't have important signs and symptoms and don't refer to medical care. We rely on animal models and we divide the natural history of the disease into three phases: induction, inflammation, and destruction. Induction is mostly seen in the mice you immunize, but you don't recognize it in patients. So, induction phase. If you immunize animals with triggers that commit to the development of an erosive synovitis, together with a subcutaneous adjuvant, you will notice it will take time for this erosion to occur, also several weeks. If instead you check what is happening in the synovia after 10-12 days, you already find systemic changes of the synovia such as hyperplasia, fibrin, and vasodilation. What is not found, and is typical of general inflammation, is recruitment of leukocytes. It is not very clear what is going on. Overall, we think that after 10 days, all the membranes are getting hyperplastic because they are preparing to react. Some mice will then heal normally and not develop the synovitis, while others will develop a strong leukocyte inflammatory infiltrate, so neutrophils, monocytes, and lymphocytes. At least in mice, the evolution towards healing or inflammation depends on the genetic background of this. Some mice will heal and revert back to homeostatic response, while other mice undergo a vicious cycle in which inflammation will persist. Inflammation thus causes the typical pathological changes seen in erosive arthritis disease. So, in the first step, we have innate immunity. First step is induction. It's innate immunity that is involved and is reversible. Step 2, we have inflammation. We have involvement of Th17 and B cells and it's reversible. Step 3, we have destruction, so osteoclast activation, less inflammation, and irreversible. Induction phase, we have activation of synoviocytes precedes the entrance of antibodies and cells in the joint and causes expression of chemokines, receptors, and cytokines. We have development and exposure of citrullinated proteins, release of DNA and nuclear material, so danger signals, activation of immature dendritic cells, and generation of chemokines and recruitment of inflammatory cells in the joint office. Inflammation phase. Injection of the adjuvant and immunizing materials delivers signals to the synovial cells, and either you are able to directly activate synoviocytes and macrophages or activate them indirectly by the release of endogenous mediators. After activation, they will release cytokines and chemokines for inflammatory infiltrate generation and prepare the joint for further steps in the disease. At this point, the crosstalk is more complicated because there are not only inflammatory signals activating cells, but you attract acutely also CD4 positive T cells, which are in general memory cells and will interact with antigen presenting cells within the synovia. As a consequence, the pathogenic cells are mostly the CD17 positive T cells that will sustain activation of macrophages and in particular of synoviocytes leading and a crosstalk calling B cells in the site of disease. B cells were ignored for a long time until rituximab was tried in rheumatoid arthritis and was found to work pretty well. B cells in rheumatoid joints create an ectopic germinal center, like the ones we find in lymph nodes where B cells undergo symptomatic hypermutation and affinity maturation under the control of lymphocytes T cells. There is strong evidence showing that most of the autoantibodies important in the disease are produced in these ectopic germinal centers, like rheumatoid factors and autoantibodies able to recognize citrullinated proteins. Possibly the most pathogenetically relevant event is the crosstalk between T cells and synoviocytes fibroblasts, convincing them to change and to proliferate, so giving rise to huge synovial hyperplasia. They acquire the ability to invade the surrounding tissues. It infiltrates the mold and erodes it, and they are the main cells in charge of releasing angiogenic signals, so to keep the hyperplastic synovia nourished by attracting new vessels. If you think about cells that hyperproliferate, are able to infiltrate surrounding tissues and release angiogenic factors, you immediately think of cancer cells. Indeed, there are similarities in these synoviocytes and cancer cells, and if you check the p53 status of synoviocytes, you often find it mutated or defective together with also microsatellite instability resembling which what could occur in a real transformation of synovial cells. These cells are called fibroblastoid synoviocytes to remind us that they definitely are different cells from the normal synoviocytes. This inflammatory phase is not known how often it occurs in normal situations. It is quite possible that in certain conditions, especially after infections in which we have arthralgias, that something like this is happening. But the real marker of rheumatoid patients is that this inflammatory response does not terminate after a while, as it should, but it persists, and the last phase of the process is osteoclast involvement. So, in the inflammatory phase, we have entry of memory CCR5, CXCR3 positive T lymphocytes, recognition of antigens, release of TNF, IL-6 and IL-17, various cytokines induction, B cell activation, activation of osteoclasts, and induction of matrix metalloproteinases, at least the initial induction. You have loss of p53, microsatellite instability. The third phase is destruction. In osteoarthritis, you have bone injury with an osteoclastic response to remove the injured tissue. In rheumatoid arthritis, the signals generated by T cell synoviocyte macrophage crosstalk directly activate. In RA, the signals generated by T cell synoviocyte macrophage crosstalk directly activate the osteoclasts. The erosions in rheumatoid arthritis are pretty typical because they have osteoclastic degeneration of the tissue, but there is no osteoclastic activation in order to remove the debris of the degenerating tissue. This process is seen also in radiology images. At arthroscopy, we have normal articular surfaces and medial meniscus. So you see here on the image. Okay, you can see also the edematous hypertrophied villi are characteristic of more advanced rheumatoid arthritis. Characteristic hyperemic proliferative synovium with normal cartilage in early rheumatoid arthritis. The X-ray images, we see that normally we see a space between the bones because it's where articular cartilage, which is radiotransparent, lies. In this case, the third metacarpophalangeal joint has collapsed and the irregularity seen at the previous X-ray now involves the entire bone head. So this picture shows the classical symmetric, additive and destructive joint involvement of typical RA. We did indeed treat the patient during all those years, but unfortunately the patient did not respond well. So the clinical features are constitutional features like asthenia with loss arthralgia, low-grade fever, mostly related to cytokines production. We then divide rheumatoid arthritis presentations into categories. Articular manifestations nowadays are the predominating symptoms because we have more effective therapeutic options. We have extra-articular manifestations, so vasculitis and its cutaneous manifestations, and pulmonary. We have ocular involvement. Pulmonary involvement is not vasculitic. Complications are cardiovascular disease, which is the main cause of death in rheumatoid arthritis patients, both because of the complications of the disease itself and of its treatment. We have lymphomas, osteoporosis. Specific syndromes are Kaplan syndromes, which is silicosis. plus array, and Felty syndrome, which is neutropenia, splenomegaly, and rheumatoid arthritis. Articular manifestations are clinical signs, like inflammation. Not all the typical signs are seen in rheumatoid arthritis. Patients seldomly present with warm or red joints. Often they are swollen, painful, and stiff. Possible associations of mainly present tumor dolor and especially functional rubor and color can or cannot be present. With possible associated bursitis or tenosynovitis. As radiological signs, we find erosions. The most involved sites are the proximal interphalangeal, the metacarpophalangeal and metatarsal phalangeal, the wrists, elbows, shoulders, knees, and ankles, C1 and C2, and other like the temporal, mandibular, and sternoclavicular. Pain can vary pretty much between patients, different quality depending on the type of damage. We have synovial expansion, which is dual and continuous due to the growth of the synovia. We have damaged bone and cartilage, which is sharp and stabbing due to involvement of the periosteum, which is highly innervated. We have also stiffness, which is very typical of inflammatory arthritis. More frequent and important during the night and early morning, where we have a peak of IL-6 and it's relieved by movement. We have also difficulty in manipulating or holding objects. We have a sense of swelling because there is something growing inside. Deformities are a late event in rheumatoid arthritis, but they are typical. Um, Most important patterns are swan neck deformity. It occurs with an extension of the distal phalange, boutonniere deformity, and mallet finger, which is an hyperflexed distal interphalangeal joint due to the rupture of the extensor slip. These are not due to bone erosion per se, but to the destruction of the points of attachment of tendons to bones, resulting in loss of mobility and assumption of deformed position. This can occur also in the feet. We have an ulnar drift, which is again related to the different accommodation of the relative strength of the end tendons, which is due to metacarpophalangeal joint synovitis that weakens the dorsal-radial capsular restraints, loosening of the metatarsophalangeal joint collateral ligaments, resulting in decreased stability, and stretching of the flexor tunnels that permit even more ulnar displacement of the long flexor tendon. These deformities were occurring in almost all of the patients in the late phase and were a major cause of disability for the patients. We have also the Baker's popliteal cavity cyst. So always check the patient's popliteal cavity. It is a distension of the gastrocnemius semimembranous bursa, which communicates with the knee joint via an opening in the joint capsule posterior to the middle femoral condyle. Both in osteoarthritis and rheumatoid arthritis, if there is damage in the joint capsule in the point in which the secondary synovial pouch is connected to it, there can be swelling and hemorrhage. Remember, it is not a true cyst but a distension of a fluid-filled bursa. Per se, it's not a pathological except that it's painful. Rupture can give rise to an acute inflammatory condition that is almost always as confused with thrombophlebitis. In the spine, remember that it does not have synovial joints except for the C1 C2 which allows for the wide range of head movements. The atlas joint, in fact, has synovial pouches surrounding the odontoid process that can be or not a not so rare site of rheumatoid arthritis. The rheumatoid synovia destroys the transverse ligament that holds the odontoid process in its position. Once this ligament is damaged, the odontoid starts pressing against the spinal cord, and we can have an atlantoaxial dislocation. The cord in turn has nerve fibers that control the movements of the limbs. The synovia can erode through the bone of the odontoid process, destroying the joint. Patients should undergo spine MRI for evaluation of such condition, and it must be promptly recognized, as it is a medical emergency if there is spinal compression. Our effort is to identify the patients as soon as possible because the earlier we interfere with the pannus formation, the better the prognosis of our patients. Diagnosis is made through inflammatory markers like CRP, which is typically quite elevated in contrast to the systemic autoimmune diseases, ESR, hemoglobin, and ferritin. have autoantibodies like anti-CCP and rheumatoid factor, and in the synovial fluid it can be informative, although it's not necessary for diagnosis. So, synovial fluid is not necessary for diagnosis. There are no specific findings for rheumatoid arthritis, but it can help with differential diagnosis. The characteristics of the fluid are typically cloudy, with low viscosity as seen in the picture. This appearance can be found also in septic arthritis that it has differential diagnosis of rheumatoid arthritis, especially in the early and monoarticular phase. We have a white blood cell count, leukocytes are present, but not as many as in septic arthritis. Many of the cells are neutrophils. We have culture of the fluid should be negative in rheumatoid arthritis, so because it's a sterile condition, and optical microscopy analysis with polarized light to search for crystals should be negative in rheumatoid arthritis. It helps to differentiate it from crystal-associated arthropathy. We have also extraarticular manifestations. So some extraarticular features that might be useful to identify rheumatoid arthritis patients affect up some extraarticular features might be useful to identify rheumatoid arthritis patients. They affect up to 40% of patients and 1% severely. They harbor a 5% increased risk of death. Most of them are associated to small vessel vasculitis. The most frequent features are subclinical endothelial activation and maybe increased risk of thrombosis, subcutaneous rheumatoid nodules, nodules over bony prominences generally adherent to the periosteum. At histology, they show fibrinoid necrosis surrounded by fibroblasts. They are more frequent in HIV-positive rheumatoid arthritis patients, typically found also on the dorsum at areas of greatest mechanical exposure on the bone surfaces. They can help with the diagnosis of early rheumatoid arthritis, especially when monoarticular disease is present. They are unfortunately often associated with early destructive rheumatoid arthritis with high titers of cetroninated peptides. We have also lung nodules. Other occasional manifestations can be periungular infarcts, gangrene of the fingers and leg ulcers, distal neuropathy, renal vasculitis, 20% of cases ANCA-associated, but they are very rare. The lung is frequently involved in a nodular pattern which is seldom important for the clinical point of view, but must be recognized in patients with other pulmonary comorbidities. There is also often an inflammatory reaction of the pleura which should not be overtreated because they can be transient. We have pleurisy, which is common, frequently asymptomatic, otherwise we have dyspnea, presence of multinucleated giant cells, which is typical. We have pulmonary nodules that are not so common anymore with therapy, can be vasculitic. At histology, we find fibrinoid necrosis plus fibroblasts, complications like cavitation, fistula, pleural emphysema, and superinfection, especially because patients are treated with immunosuppressive agents, typically mycotic in origin. We have interstitial lung disease in 9.5% of cases, obstructive disorders that can lead to bronchiectasis, like cryptogenic obstructive pneumonia, which has a better prognosis, constrictive or obliterative bronchiolitis, which has a poor prognosis, obstruction of the upper airways, like dysphonia, dysphagia, and phonodynia, and Kaplan syndrome, which is pneumoconiosis plus rheumatoid arthritis. In the eye, you can have Zika syndrome, which can be a true Sjogren's syndrome without lymphocytic infiltrate associated to Sjogren. We have keratoconjunctivitis sicca in 10% of cases, episcleritis with redness and eye pain, nodular or diffuse, progression in scleromalacia, pretty rare if not treated, uveitis, episcleral nodulosis, ulcerative keratitis. In the heart, there is a growing awareness in the field that we should treat these patients very carefully because the pattern of inflammation that remains active despite treatment in the disease can give a high burden of cardiovascular complications with morbidity and mortality. This increased cardiovascular morbidity has been studied by comparing rheumatoid arthritis population score with the corrected cardiovascular risk factor. They must be treated as high cardiovascular risk patients, although it is possible that in the future we will have better markers for these patients. We can have pericarditis, which is the most frequent, inflammation of the parenchyma, with nonspecific myocarditis and nodular granulomatous lesions or fibrosis, ischemic heart disease with coronary arteries, arteritis and thrombophilic diathesis, and others can be liver, kidney, and CNS involvement are usually not clinically relevant. In the liver, we can have no specific elevation of liver enzymes or hepatomegaly, which is frequent, portal hypertension from cirrhosis or portal fibrosis. In the nervous system, we can have transverse ligament injury, odontoid process erosion, peripheral neuropathy, vasculitis or due to nerve entrapment, and pachymeningitis, which is rare. In the kidney, usually late and rare, we can have glomerulonephritis, which is vasculitis, and amyloidosis. Diagnosis. There are classification criteria for the rheumatoid arthritis, which are often also used for diagnosis. These are the 1987 criteria. There is no mention of autoantibodies as they hadn't been detected yet. If you had all 7 of the criteria, you were pretty sure your patient had rheumatoid arthritis. As a joint effort of the European and American Rheumatology Association, these criteria have been changed completely, and now there is a score that is given for each category. This update was thought of because of the need of identifying patients with early rheumatoid arthritis in order to start early treatment. In 1987, when you decided to treat patients, you were giving really toxic drugs, so you had to be sure that the patient had rheumatoid arthritis. Now it is the opposite of what we do now. Because if we wait too long to treat the patient, he will suffer bone erosions and we will lose the most beneficial therapeutic window. Novel agents for rheumatoid arthritis are mostly biological drugs which cost very much. For instance, in reactive arthritis, the patient would benefit very much from anti-TNF therapy. It will act as a monocyclic rheumatoid arthritis which then disappears. In this way, non-rheumatoid arthritis patients will get symptomatic benefit because of the therapy, while we will be sure not to miss any early rheumatoid arthritis, which have not yet progressed to obvious signs and symptoms. So these are the classification criteria. We have the old ones are morning stiffness at least 1 hour, arthritis in 3 or more joint areas, arthritis of end joints, more than one swollen joints, symmetric arthritis, rheumatoid nodules, serum rheumatoid factor, radiological changes, erosions on X-rays of hands. Positive in case of 4 of the 7 criteria must be present. Criteria 1 through 4 must have been present for at least 6 weeks. Presentation. The onset typically isn't striking and involves a minority of joints with then an additive progression of the disease. Onset of rheumatoid arthritis as an acute arthritis of a single joint is very rare. Some patients can present rather than with joint symptoms with constitutional and systemic symptoms. Can have an insidious polyarticular, typical infrequent or monoarticular, so then acute polyarticular, more frequent in elderly patients, and acute monoarthritis, which is rare, very atypical. Can have local or systemic extraarticular manifestations also. Progression, you can have a monocyclic, one acute event of durable remission, polycyclic or progressive pattern, which resembles what is seen in multiple sclerosis. The degree of disability is extremely variable. The main cause of death are cardiovascular disease. We have also citrullinated antigens. There are ineffective environmental factors, especially damaging the upper airways and causing citrullination. In certain patients, antibodies can be generated which cross-react with synovial antigens and amplify the inflammatory response. Citrullinated components are typical constituents of NETs, and indeed they are generated by activated neutrophils, both by infection and sterile stimuli, which are important for rheumatoid arthritis. These components are efficiently recognized by these autoantibodies, thus further creating a link between the two mechanisms. So anti-CCP antibodies have a specificity of 95%, a sensitivity of 75%, positive predictive value of more than 90%, have a correlation with severity of erosions and a positive even in the early stages or before. In the lung, infections activate immune cells, resulting in protein citrullination and transient rheumatoid factor production enhanced by smoking. Then, in genetically predisposed individuals, ACPAs emerge. Citrullination may take place in the synovium and immune complexes of preformed ACPAs, and citrullinated fibrin may accumulate, contributing to autoimmune synovitis. Rheumatoid factor is usually of IgM class, positive in 60–80% of the full-blown uh, rheumatoid arthritis, less specific for rheumatoid arthritis, less specific than anti-CCP antibodies, physiologically useful for increased immune clearance, possible pathogenetic role at activation of the complement, maintaining inflammation, presentation of antigen, and clearance of immune anti-CCP positive.